Partial distal biceps tendon tears, often abbreviated as PDBTs, represent a spectrum of injuries that can range from small microtears to nearly complete ruptures near the elbow. These tears may result from either traumatic events such as sudden heavy lifting or from gradual degeneration over time. Traumatic tears typically affect the short head of the biceps, while degenerative tears can involve either or both heads, often starting at the lateral fiber. Condition is being recognized more frequently, thanks in part to advances in imaging like MRI. However, the true prevalence in the general population remains unclear. Unlike complete tears, which usually present with obvious pain, deformity, and weakness, partial tears can be subtle with symptoms like vague pain, occasional mechanical clicks, or mild weakness. This variability often leads to delays in diagnosis and treatment, making awareness and early recognition crucial for optimal outcomes. Diagnosing partial distal biceps tendon tears requires a careful combination of patient history, physical examination, and advanced imaging. Patients often report pain in the front of the elbow or forearm, sometimes accompanied by weakness during lifting or twisting motions. Several clinical tests have been developed to improve diagnostic accuracy, such as the tilt sign, the resisted hook test, and the biceps provocation test. These tests help distinguish partial tears from other conditions like tendinosis or bursitis. Imaging, especially MRI, plays a vital role in confirming the diagnosis and assessing the extent of the tear. Standard radiographs can reveal bone changes, while MRI provides detailed views of the tendon and surrounding structures. In some cases, specialized MRI views or dynamic CT scans are used to better understand the injury. Accurate diagnosis is essential for guiding treatment decisions and improving patient outcomes. Treatment for partial distal biceps tendon tears depends on the severity of the injury, patient activity level, and imaging findings. Non-surgical management is often the first step, especially for low-demand patients or those with degenerative changes. This includes physiotherapy focused on isometric strengthening, activity modification, and sometimes guided injections such as corticosteroids or platelet-rich plasma. Surgery is considered for patients with persistent symptoms, larger tears, or those with high functional demands. Surgical options range from minimally invasive endoscopic procedures to open repairs, addressing not only the tendon but also associated issues like bursitis or bone spurs. The choice of technique is tailored to the individual, aiming for pain relief and restoration of function. Most patients experience good to excellent outcomes, whether managed conservatively or surgically, provided the treatment is matched to their specific needs. Clear understanding of the anatomy and biomechanics of the distal biceps tendon is essential for both diagnosis and treatment. The biceps muscle has two heads, short and long, that may remain separate or merge before attaching to the radius. The short head is typically a stronger flexor, while the long head is more involved in supination, though recent studies suggest these roles can vary. Way these tendons insert and interact with surrounding bone structures, like the radial tuberosity, influences both the risk of injury and the approach to repair. Variations in anatomy, such as discrete tendon insertions or bone spurs, can predispose individuals to partial tears or affect recovery. Recognizing these differences helps clinicians tailor both conservative and surgical management to achieve the best possible outcomes for each patient. Most patients with partial distal biceps tendon tears can expect favorable outcomes with appropriate management. Non-surgical approaches often lead to significant pain relief and functional improvement, especially when patients adhere to a structured rehabilitation program. Surgical repair, when needed, also yields high rates of satisfaction and return to activity, with most individuals regaining strength and range of motion. Rehabilitation is a gradual process, typically spanning 3 to 6 months, and focuses on progressive strengthening and safe return to daily activities or sports. Complications are relatively uncommon, but can include nerve irritation or rarely re-rupture. Ultimately, early recognition, accurate diagnosis, and a patient-centered treatment plan are key to achieving the best results and helping patients return to their normal lives.